Welcome to another episode of Clear Lake Connections, where we talk to the people behind the businesses of Bay Area Houston, proudly sponsored by UTMB Health. Today's special guest is Dr. Carmen Mora with UTMB. And what is your specialty?
Pediatric surgery.
And how did you get involved with that? At what point do you decide that you want to? Because that's got to be a kind of a challenging specialty.
It is. I actually got interested when I was a medical student. When I started medical school, I wanted to be a pediatrician. I always wanted to help children. I thought that, health and, just all the diseases that children undergo are very unique. And I think it's much more rewarding a lot of the times when you help children, that I wanted to do something with that. And then when I got into medical school, I got into my surgery rotation, and I thought it was fascinating. And I didn't actually realize that pediatric surgery was a specialty. So from then on, I kind of pursued to wanting to become a pediatric surgeon, which I just finished my training past summer.
Okay, and so now you're going in. So now you're starting rotations and stuff. At the hospital.
I've started my practice. So
okay.
After finishing with my fellowship in July, I started as an attending faculty surgeon at UTMB in September.
Explain a little more about that, because I'm not sure everybody understands kind of the progression from college to medical school, and then you said a fellowship.
Yeah. So it is a little bit different for every person, and I think surgeons tend to have probably some of the longest trainings. For medical school, it was 4 years. From there, it was a general surgery training where you kind of learn all the principles of general surgery, and from there you kind of subspecialize. That's when, after that, I went on to do a fellowship, so that's when you subspecialize in something. So I did my general surgery training, and then I did a couple other subspecialties prior to getting to pediatric surgery. So if you want to subspecialize, you kind of have to do a couple years after your base training. So for radiologists, it'll be a residency in radiology, and then some of them go on to do special training such as interventional radiology. So that's some other training on top of it. And once you're done with all your training, then you can actually start as a faculty member, or if you're in a teaching institution, they call you an attending.
And so what brought you to UTMB? What drew you towards UTMB?
So I initially got drawn to the area. My family's in Houston. They actually live in North Houston. I grew up in Houston, and so I wanted to come back and help the people that I actually grew up with. And the reason I came to UTMB, there are tons of great facilities in Texas, especially in Houston, as we know from the medical center. However, the reason I was drawn here is because it allowed me to actually be able to take care of all patients of all varieties. It's a very close-knit group that we have, so your partners very intimately, and you're allowed to work with patients from all ranges instead of being further subspecialized, as if you go to other institutions, you end up doing only one or two things. I also find that the broader groups of patients that we can see, we do see some very underprivileged patients in Galveston as we kind of go out to the Angleton area, to the more rural parts of the state that we don't get to see sometimes in the inner city urban kids. So I wanted to be able to kind of help in all facets of all of our patient populations.
What's the biggest challenges of pediatric surgery versus general surgery?
I think the biggest problem we have is that, operating on children is very difficult, not only from a technical aspect, but sometimes the tools and the specialties that we need to take care of them aren't as numerous as they are in adults. So when you go into a hospital, despite it being in a community hospital or, really large medical center, you have all of the devices that you'll need. However, when you start talking about treating children, we start to become much more scarce in those supplies. So if you go to a community hospital, they may not have the equipment that they need to actually intubate a patient or even put a simple IV. So it becomes so subspecialized, not only from a surgical standpoint, but from also a just standard pediatrician level, that I think that getting care, especially surgical care to children, becomes very difficult. So there's only very few centers out there that can actually do the job. There's, luckily in Texas, we have quite a few large children's hospitals, and then we have other hospitals throughout that are able to take care of children. But thinking about the number of children that we have to take care of in the state of Texas, I think we still are underserving our populations and kids based on the amount of availability that we have.
Because it's all kind of concentrated in,
it's all very
in the metro
concentrated.
areas.
Exactly.
Yeah.
So if you think about it, in Houston, our population is very large, and two of our largest children's hospitals are right next to each other. There are some that are scattering throughout, trying to, help that, but I think we're still very concentrated in certain areas, and we're not helping the amount of kids out in the rural populations, which I think is a national problem. It's not a, particular problem to Houston or Texas itself.
Yeah, healthcare in general is kind of confined to those most populous areas. Hard to find a good family country doctor anymore.
Exactly. And I think once you start talking about, care for children, it becomes even more problematic. Trying to get your kid to a surgeon when you live 4 hours away from a children's hospital is pretty difficult. So we're trying our best to try to, expand as a profession to help children everywhere, because we deep down all believe that every child deserves a good, standard, appropriate health care and good access to care. So it shouldn't take you 4 hours to get somewhere, to get simple care. Specialized care, it's different.
Mm-hmm.
However, I think in your bread and butter, taking out an appendix, having hernia surgery, I think it should be much more readily available and easier to get to than having to wait months or travel, 4 hours to get somewhere.
So you mentioned that access is a problem, but you're doing something about that. Tell me about that.
So we've actually started opening more clinics out regionally. As we talked about, it's not only having access to a hospital that can do this, but sometimes all you really need is a pediatric surgeon for evaluation. So we've actually opened up 2 clinics. One's in Pearland and one is in Pasadena. And we're also working with our maternal fetal medicine group to, work with our OBs, because our job doesn't start, at birth. It starts before birth for all these congenital anomalies. So we want to make sure that mom and dad are very well aware of what they expect for all of these things, especially if their child is going to require surgery. So we can have those conversations ahead of time and be, more prepared as to what they're going to expect. And we can, move forward as to what they'd want and answer any questions that may come up. So we're working hard to try to, expand our services outside of just our 2 hospitals, with a caveat that, you still have to come in to have surgery. But I think we all understand that, we can't give those large resources everywhere, but I think you can have the ability and the access to at least the specialists of the surgeons in your community, and not have to travel far.
Well, that's awesome. So we talked about how most of these things are, genetics at birth. How early into a pregnancy can you find these anomalies so that you can start preparing parents and having those discussions?
So most pregnancies will have what we call our anatomy scan at 20 weeks of gestation. So at that point, we can usually find out if there's anything that's concerning for a patient. Sometimes it's not as obvious, and they do have repeat ultrasounds, but usually about at 20 weeks, the maternal fetal group can actually know if there is something. We normally come into the picture for a variety of different things that are known not to resolve. Some of them can resolve or improve as time goes on, and then we can kind of get involved usually like a little bit later in the 2nd trimester or 3rd trimester. But majority of the time, it's usually after that 20-week ultrasound that they'll kind of know that a pediatric surgeon is going to be necessary.
And then are there surgeries where you have to do it as soon as the baby's born? There
are a couple of surgeries that are very risky when the patient comes out, and if we don't operate immediately, it can lead to, infant demise. One of them is if they have very large tumors, or we call sometimes cysts, that is encroaching on their airway, so it collapses the trachea and they can't breathe. So in those cases, they need a special procedure, what we call an exit, where we technically leave the patient hooked up to the mom's placenta and allow that to become more of a bypass. So it's like a bypass machine. So mom's kind of pumping the blood through the baby while it allows us to operate, either just, get a breathing tube in the baby or actually remove the mass in itself. There's a couple other things that is similar to that where we end up performing what we call this exit procedure. Fetal surgery itself has actually gone away from, being the standard and normal. Where I trained at UCSF, that's where fetal surgery was born, and they used to do a lot more where they'd go in, open the uterus, do surgery, and put baby back in. That's actually now gone away with some of the inventions and new modern treatments that we do have for a lot of different things. So it's rare, but now the thing we still do is what we call an exit.
So what are some of the more common surgeries that you perform at the pediatric level?
So from a standard everyday, appendicitis, inguinal hernias, umbilical hernias, in smaller babies, something that we call pyloric stenosis is very common. It's where the muscle that goes from the stomach to the small intestine, it separates the two. Sometimes will get very thickened. And what happens is that babies can't pass food through. So as they take their milk, they'll just kind of throw it up, and it prevents them from being able to grow. So what we do is we actually split that muscle and allow things to move forward, and it's what we call a pyloromyotomy. It's one of our most common procedures that we do for young babies. And then routinely, there's a lot of different congenital anomalies that we do deal with, anywhere from congenital diaphragmatic hernias, where you have your diaphragm that's missing and your intestines can go up to your chest. We have atresias where your GI system doesn't connect well, so they're disconnected, and it can happen in your esophagus, in your small intestine, or your colon. And then something else that's very common is what we call an anal rectal malformation, and that's where you don't have a anus in your rectum coming down. So we have to create you what we call a neoanus from a different procedure. So there's a very wide breadth of things that we do on a routine basis. Some of those are a little bit more complex than other procedures, but they're all fairly common and routine.
So let's say you're having a normal day.
Mm-hmm.
How much time are you actually spending over the operating table, on procedures?
It depends on the week. Normally, it's at least one day of elective cases, and then depending on emergency cases that come in, one or two cases every other day. It all just depends. So appendicitis tends to be more of an emergency. So there are weeks where we have a run and there's like an appendix that needs to be taken out, 2 to 3 a day. Sometimes we go a week and there's no one that comes in. It's very bizarre, similar to pyloric stenosis, where they come in. Those kids may come in 2 or 3, and then we may not see them for a couple of weeks.
Strange patterns.
It's strange patterns. We never project it. So on the emergency cases, it can vary from like a very busy week to maybe 1 or 2. But then you have your elective case day.
So what's the longest you've ever been in one surgery?
That would be probably about 16 hours.
Wow. And you're just the whole time over the operating table?
You take small breaks throughout. You do need to stay a little bit hydrated, and then take a small bathroom break. But otherwise, you have to stay focused on it.
I mean, for most of us, sitting 8 hours at a desk is, our job. That double that, standing over somebody, that's pretty remarkable.
It is. I've always found it really interesting how we can go so long without realizing the time, but it flies by fairly quickly.
Yeah.
And those are usually your more complex cases where, we do, on top of all our, GI surgery, we do tumor surgery also. So there are some children that will come in with very large tumors in the abdomen that sometimes encroach vessels, and it's a very difficult thing trying to peel them off very, important structures such as the aorta, the pancreas, and it's time consuming. So those are the ones that'll take quite some time, but even then it's, very rewarding when you're done at the end of it and you don't realize how long you've actually been in there the whole time.
Well, you're engrossed in your work, it sounds
exactly.
like. Yeah.
So it's like I think if you ask an artist, when they start seeing something and they go on in painting and finally want to put it all on a canvas, they don't realize that 8-10 hours have passed by and they're like, oh, wow. They're just so focused in putting it in that they just lose track of time. And I think that's kind of what we do.
So what are your hopes and aspirations for not only your career, but kind of where pediatric surgery is headed?
So one of my biggest goal in pediatric surgery is to actually further expand our minimally invasive opportunities that we have for children. So in adults, we've done a really great job of pushing the envelope forward with, laparoscopy in certain cases, robotic surgery, which is something that I want to do for children. We've all been slightly apprehensive, and kind of goes back to what I said earlier about, we don't have the resources that the adults have. And a lot of the times we have to kind of change things around to adjust it for children. The robot has actually been around for a long time, and everyone talks about robotic surgery. The robot was not invented for children, and we've had to make some adjustments to allow us to use it for kids and allow them to have that same opportunity that adults have from the robot. But I think as we move forward and work with industry, we should be able to find new equipment and new materials that allow us to do same surgery we do in adults with smaller incisions and smaller instruments for children. So that's kind of one of my biggest hopes and kind of, pushing forward. We did actually start a robotics program already here at UTMB, and we've done, more than 10 cases already since they started in September. And our hope is to actually continue to move that forward. And in conjunction with our pediatric urologist, our cases should increase. So the volume is there, and our patients do need it. We just kind of need to make sure that we have the right patient selection. And as we move forward and industry starts to see that we are using it, they can kind of hopefully work with us to allow better instruments that will better accommodate our patients.
Yeah, it's the same physiology, but on a smaller scale. And
for the most part, it is.
Yeah.
There are slight changes to children and how physiologically they do. Some of them are actually much sicker than adults, just based on how, sometimes when they're sicker, it's not because of what they've done to their body, but more from what they were born with. So their heart problems tend to be more structural, so meaning that their heart wasn't developed the same way everyone else's is normally. So you have to be a lot more careful. Versus adults, when you have heart problems, it's mostly just from diseases that you've had occurred over time. And it's slightly different kind of working with those kids, but still a little bit challenging.
So it's mostly congenital at that
Exactly.
point. Okay.
For our patients, and most of the time it's all congenital as to why, things are not going the way they're supposed to go.
Well, we appreciate the work you're doing, and thank you so
you.
much for joining us.
No, definitely. Thank you for having me.